So hi friends, today I would like to discuss about ABG analysis, arterial blood gas analysis. So starting with the normal values, the normal pH is 7.35 to 7.45. The normal PCO2 ranging from 35 to 45 mmHg, and the normal bicarbonate level is like 21 to 27 milliequivalent. But for the calculation purpose, we are taking 7.40 as the normal pH, 40 as the normal PCO2, and 24 as the normal bicarbonate. So the first step of ABG analysis is that look at pH. If it is less than 7.40, it is acidosis. It is called acidosis. And if it is more than 7.40, it is called alkalosis. Again, the acidosis can be metabolic or respiratory. Similarly, the alkalosis can be metabolic or respiratory. So, acidosis can be either metabolic or respiratory. Alkalosis also metabolic and respiratory. So, to determine whether it is metabolic or respiratory, we have to check the primary disturbance. If the primary cause for acidosis is decrease in bicarbonate, then it is metabolic, or increase in PCO2, then the cause of acidosis is respiratory. Similarly, for alkalosis also, if it is due to increased bicarb, it is metabolic alkalosis, and if it is due to decreased PCO2, it is respiratory alkalosis. So we know that the bicarbonate is alkaline component. So whenever it decreases, it can cause acidosis. Whenever the alkaline bicarbonate increases, it will cause alkalosis, metabolic alkalosis. Similarly, the PCO2 is an acidic component. Whenever it increases, it causes acidosis. Whenever the PCO2 decreases, it causes alkalosis. So let us discuss one by one. First, starting with the metabolic acidosis. As already discussed, the primary disturbance is in decrease in bicarbonate. So the compensation for metabolic acidosis is it has to be compensated by some alkaline response. The alkaline response is by decreasing PCO2. So the change is always in same direction. Whenever bicarbonate decreases, the PCO2 also decreases to compensate it. So how can we calculate whether it is adequately compensated or the compensation is inadequate or concomitant and other diseases like respiratory acidosis or alkalosis? Let us check. The formula used to check the compensation is called Winter's formula. It is called Winter's formula. The formula is 1.5 into bicarbonate plus 8 plus or minus 2. This is the formula. Kindly make a note. This is bicarbonate, not change in bicarbonate. This is serum bicarbonate. Okay. So let's do an example. Suppose the ABG of a patient looks like pH is 7.30, bicarbonate is 18, PCO2 is 36. So first step is looking at pH. pH is less than 7.40, then it is acidosis. So the look for the cause of acidosis. Acidosis can be either due to increased PCO2 or decreased bicarbonate. There is no increase in PCO2. PCO2 normal value is 40 and it is decreased. So the PCO2 change is not causing acidosis. Then what is causing acidosis? It is due to bicarbonate loss. Bicarbonate is 80. So the primary pathology is metabolic. It is metabolic acidosis. So now we have to check for the compensation. So we are expecting the PCO2 is like 1.5 into bicarbonate is 18 plus 8 plus or minus 2. That is the we are expected PCO2. So it is like 27 plus 8 plus or minus 2 is equal to 35 plus or minus 2. That is we are expecting a PCO2 at a range of 33 to 37. This is the expected PCO2, and in our patient the PCO2 is 36. So the compensation is adequate compensation. What if the PCO2 of the patient is 30? If PCO2 is 30, don't call it undercompensated. Instead, it is a concomitant respiratory alkalosis. Okay. Don't use the term undercorrected metabolic alkalosis or metabolic acidosis. It is metabolic acidosis with concomitant respiratory alkalosis. That is a correct term to explain this condition. And what if the PCO2 is 40? Our expected range is 33 to 37, but here the PCO2 is 40. Don't use the term overcorrected. Instead, it is metabolic acidosis with metabolic acidosis with concomitant respiratory acidosis. Okay, that is the correct terminology used. Now, for metabolic acidosis, we have to calculate the anion gap. For metabolic acidosis only, not for other conditions. For metabolic acidosis, we have to calculate anion gap. What is anion gap? Anion gap is simply sodium, that is the cations minus anions. The main cation is sodium minus the anions. Anions are bicarbonate plus chloride. This is how we are calculating anion gap, assuming the albumin is normal, and the normal range of anion gap is 10 to 12. For the calculation purpose, we will take 12 as the normal value. So after calculating the anion gap, we have to check the delta ratio. So the delta ratio, these things are only applicable to metabolic acidosis, not in metabolic alkalosis or respiratory conditions. Okay, the delta ratio, the equation is measured anion gap minus normal anion gap divided by normal bicarbonate minus measured bicarbonate. Okay, so the measured anion gap, the normal anion gap I have already told, it is 12 divided by normal bicarbonate, it is 24 minus measured bicarbonate. So this is the equation for delta ratio. Now how to interpret the delta ratio? If it is less than 1, it is hagma plus nagma, that is high anion gap metabolic acidosis plus normal anion gap metabolic acidosis component is also there. That is why we are calculating the delta ratio. We want to know whether the condition also having normal anion gap or concomitant metabolic alkalosis, like that. So that is why we are calculating delta ratio. And if it is less than 1, the interpretation is hagma plus nagma. And if it is 1 to 2, it is pure hagma. There is no normal anion gap metabolic acidosis associated. it is pure hagma, and if it is more than 2, it is hagma plus metabolic alkalosis. Okay, this is how we interpret the delta ratio. I'm not going to the details of causes of elevated anion gap, and you know that mnemonic is mud piles. So this is how we have to interpret a case of metabolic acidosis. Okay, these conditions, the delta ratio, anion gap, everything is applicable to, and the Winter's formula also applicable to metabolic acidosis only. Okay, so moving on to metabolic alkalosis. Metabolic alkalosis. Here the primary disturbance is increased bicarbonate. So the compensation we are expecting is increased PCO2 by respiratory mechanism. Okay, so here also we want to know whether it is adequate compensated or not. So the formula here we used is like delta PCO2, that is change in PCO2, is equal to 0.7 into delta bicarbonate. Kindly make a note, it is not PCO2, it is change in PCO2, and it is not bicarbonate, it is change in bicarbonate. Okay, so we will do an example. So this is the formula. So suppose in the ABG the pH of a patient is like 7.50, bicarbonate is 30, and PCO2 is 50. So first look at the pH. Yes, it is increased more than 7.40, so it is alkalosis. So the cause of alkalosis can be either due to increased bicarb or decreased PCO2. Here PCO2 is increased, so the cause is not PCO2, it is increased bicarb. So it is metabolic, not respiratory. So it is metabolic alkalosis. So the change in PCO2, we are looking for the compensation now. The change in PCO2 should be 0.7 into change in bicarb. Change in bicarb means measured bicarb minus normal bicarb. Normal bicarb is 24. That is how we calculate the change in bicarb. So it is 0.7 into 6. It is 4.2. So we are expecting a change of 4.2 in PCO2. That is, the PCO2 should be increased. So the PCO2 we expected is, the normal value is 40 plus this change in PCO2 is 4.2. So we are expecting PCO2 at the range of 44.2. But in our case the PCO2 is 50. So there is concomitant, it is not overcorrected. Don't use the term overcorrected here also. There is concomitant respiratory. Here the PCO2 is more now, so it is respiratory acidosis. I think it is clear. If the PCO2 was 45, the compensation is said to be adequate. Or if it is 40, there is concomitant respiratory alkalosis. This is how we interpret metabolic acidosis. Okay. Then going to the respiratory condition. Respiratory disturbances. In respiratory part, whether it is acidosis or alkalosis, for both acidosis and alkalosis, first we have to look it is acute or chronic. For both condition we have to first check whether it is acute or chronic. So for acute, it is said to be it is acute. The change in pH, of the patient to change in PCO2 ratio should be approximately 0.008. It is for both acidosis and alkalosis, no difference. We are just checking the change from the normal values. And for chronic conditions, the change in pH to change in PCO2, we are expecting the ratio at a range of 0.003. Let's do an example. Suppose the pH of the patient is 7.24, PCO2 is 60, and bicarbonate is 24. So first look at the pH. pH is less than 7.4, so it is acidosis. So the cause for acidosis, there is no decrease in bicarb, it is in the normal range. So but the by PCO2 is increased, so the cause is respiratory. So the respiratory acidosis. For respiratory condition, we have to determine whether it is acute or chronic. So we look for the ratios, change in pH to change in PCO2. So the change in pH is, normal pH is 7.40 and the observed pH is 7.24 divided by the PCO2 here is 60 and the normal value is 40. So the change here, it is 0.16 divided by the change is 20, and the result is approximately 0.008. So this is an acute condition. This is not chronic respiratory acidosis, it is acute respiratory acidosis. This is applicable for both respiratory acidosis and alkalosis, because we are just check the changes, not taking the actual values. Okay, so after we have determined whether it is acute or chronic, we have to look for compensation in respiratory conditions. So there is a box like this. Here we have acute and here we have chronic. Here we have acidosis, here we have alkalosis. So in acidosis, every increase in 10 PCO2, every change or increase in 10 mmHg of PCO2, there should be an increase of 1 milliequivalents of bicarbonate. Okay. For alkalosis, the PCO2 will decrease. So every 10 decrease in PCO2, there should be 2 milliequivalent decrease in bicarbonate. Coming to the chronic condition, for every 10 decrease in PCO2, there should be 4 milliequivalent decrease in bicarbonate. And here for chronic acidosis, for every 10 unit change in PCO2, there should be 3 unit increase in bicarbonate. Okay. So this is how we calculate the compensation. I am simplifying the table like this. We have acute, chronic, acidosis, alkalosis. So it is like 10:1, 10:2, 10:3, and 10:4. It's like delta PCO2 to delta bicarbonate ratio. So by using this, we can check the respiratory acidosis or alkalosis, whatever it is, adequately compensated or not. So don't use the term overcorrection or undercorrection. Instead, there will be concomitant metabolic acidosis or alkalosis. So that's about the interpretation of the ABG. Thank you.